I want to give you guys a video today on a topic that I've talked about this before. I know a lot of other providers in the TRT space have talked about this before, but it's TRT Clinic Red Flags. What to look out for and what to avoid in a TRT clinic. And I think it's important to periodically revisit stuff like this because there's a constant new stream of men being diagnosed with low testosterone, who are getting started on therapy, who are who are interested in perhaps exploring testosterone replacement therapy as a way to improve their health and their livelihood and quality of life, etc. So there's a constant demand and there's a constant stream of new guys coming in and trying to learn about this sort of stuff. And on the other side of that equation is there's been a boom in clinics, especially in the United States, where access to TRT is not so much of a problem in the US like it is in other countries, but access to quality TRT, access to physicians who actually know what they're doing that's the problem. That's the problem. So there's been an explosion of these big box cookie cutter, I call them clown clinics, that are designed to just sort of mass treat men. They use cookie cutter standard protocols. Everybody gets the same thing. It's the typical, testosterone, HCG, anastrozole, and then we're going to throw in some peptides. And in the really shady ones, they start throwing in things like oxandrolone, etc. And, if you're a new guy going into this space, how are you expected to know if you're getting good care, if you're getting bad care? All the clinics have good marketing. They're all going to tell you they're the best. And they're all going to, paint a very rosy picture of, being in their clinic and what testosterone can do for you. But, I'm still kind of astounded at how terrible some of these clinics are. I mean, they're really bad. And I'm not out here to say that I'm God's gift to TRT and I know everything, but my God, I mean, some of these clinics, the protocols that guys come to me on and the things that they've been told and the things that the way that these clinics operate is just sometimes I'm kind of speechless about it. It's I don't know what to say. So I put together a relatively short list of what I think are some of the red flags. It's definitely not an all-inclusive list. I'm sure you guys can have additional red flags that you can add into this list. So for the sake of the other guys who watch the video, if there's something that I missed, by all means, please put it in the comments so other guys can learn from that. So anyway, let's get into it. I apologize. I'm a little run down today. I just got back from a jiu-jitsu class, and one of the worst things about moving out of the country and taking this new job that I have is that, my work hours are really long, so I don't get to train like I want to. So it had been about a month since I've been on the mats, which for me is a really long time. So yeah, I went in today and it's all right, I'm going to have just a light class, light roll with some of the guys, just kind of get back into it. Yeah, no. The instructor today had something called a Shark Tank where, you basically stay in until you lose. And, I go to the noon class, which tends to be kind of heavy in terms of purple belt and below. So you have purple, blue, and white belts. There was 2 of us black belts that were there. So basically, as long as you keep winning, they keep throwing in fresh guys and you just keep going. As a black belt, I'm a very mediocre black belt in my opinion. I'm also 52 years old, right? So I don't, I don't move like I used to, but I ended up staying out there for 30, 40 minutes and man, I'm feeling it today. Oh my God. So I actually took some Celebrex and some Tylenol, which I rarely do because it's going to be a rough night tonight. And I know I'm going to be sore tomorrow. I've got a long ER shift in our critical section. So if I have to run to any codes, I'm going to get there. I'm going to be the last one that gets there because I'm going to be hobbling. But anyway, that is what it is. We'll get through it. So let's start off with the first one. And this would seem kind of simple, but you'd be surprised how often this occurs. When you go see a TRT clinic and you are diagnosed with low testosterone, you need to make sure that they've done a proper medical workup. So what does that mean? So there are a lot of reasons why men develop low testosterone. You can have, in broad terms, you can have a problem in the brain, the hypothalamus pituitary gland. You can have a problem with the end organ, the testicles, okay? And the differential diagnosis for the things that cause problems in those 2 areas is very different. You can have very serious underlying medical issues that maybe you don't know that you have. There needs to be a proper medical assessment by somebody who actually knows how to practice medicine and actually knows how to diagnose those conditions. You'd think that would be kind of a no-brainer, but you'd be surprised how many clinics I see and I hear from clients and patients and people that I do consults with that essentially they walked in there with like literally just a total testosterone that was low-ish, and they walked out with a testosterone prescription that day, which is terrible. That's not the standard of care. Like that's malpractice in my opinion. So if a provider wants to start you on testosterone, make sure that they've done appropriate blood work. And I think, you need to ask them, hey doc, why do you think I have low testosterone? And if they can't answer that question, if they can't give you a coherent answer, if they're just like, I don't know, man, it happens. Here's, let me run your credit card and here's your testosterone. You know what? In my opinion, you do what you want, but that's a huge red flag. I would walk out the door and I would find another clinic. So make sure that they're doing a proper medical assessment. And by the way, like, in my opinion, that includes a testicular exam. It doesn't really make much sense to not examine the end organ that is producing the hormone that you are deficient in, right? There's things like varicoceles. People get testicular cancer, or men get testicular cancer all the time. It's actually quite common and relatively common in younger men. So, obviously, like in a telemedicine setting, they're not going to be able to do a testicular exam on you. However, they should insist that you go see your primary doc or see a physician who can document that you have a normal testicular exam and you don't have a mass. Like you don't have a testicular cancer, a varicocele, some other structural abnormality that would clue somebody in to, oh, hey, maybe there's more to this than, what we call idiopathic low testosterone, which idiopathic just kind of means we don't really know. So I think that's pretty important. The other thing too is that, you should never get testosterone on your first visit. You really shouldn't. The first visit should be spent going over your labs in detail, doing a very thorough medical history and a physical examination if you're doing it in person, and then counseling. There should be a lengthy discussion about the pros and cons. Mainly the cons, because most guys I think are aware of the pros. They've been on social media, they've done some homework, but they may not fully grasp the downsides to testosterone therapy and the potential complications. So I think that the provider needs to spend, honestly, more time sort of talking them out of testosterone therapy, and essentially just educating them. Like this isn't all sunshine and rainbows, right? There are some potential downsides, and if you show up again with a low testosterone level documented, and they want to inject you on that visit, which I understand happens all the time, I would say thank you, but no thank you, and walk out the door, because that reflects the kind of care that you're going to get in the future, and it's probably not going to be very good. All right. This is a little controversial. Please don't fill in my inbox with hate. Okay. Routine testosterone replacement therapy, especially in a man, let's say mid-40s guy, he's a little bit overweight, but doesn't really have any serious medical problems. He's had a thorough evaluation. There's really nothing there. No big red flags in terms of their medical history. Treating that man is fairly routine, right? It's not rocket science. You have to be diligent. You have to keep an eye on them. You have to do appropriate follow-up and counseling and all that kind of stuff. But you don't necessarily need to be a board certified physician with 25 years of experience, right, in order to treat that man safely, adequately, etc. In fact, I'll go out on a limb and say there are many non-physicians, several that I know personally, that would do a much better job taking care of a routine TRT patient than any primary care physician that's out there who doesn't deal with TRT. Definitely way better than your family doctor, way better than your internist. And, so that's definitely a thing. So if you're one of those guys, then it's perfectly fine to see a physician. It's perfectly fine to see a PA or a nurse practitioner, even, God forbid, a naturopath. Don't love the naturopaths, but sorry. Yeah, I think that's fine. As long as they have experience and they have done some CME courses and done the adequate training. You don't want to get somebody who's fresh out of their PA or NP program, who doesn't have a ton of background clinical experience, and who also is sort of like learning on the job. Because I don't know, it's been my experience that those are the providers that really miss the mark on a lot of things. So having said that, if you have one or more like serious medical issues, and by serious, you can debate about what that means, but chronic kidney disease, let's say you've had a heart attack and you've got some stents. Let's say you've got congestive heart failure. Let's say you've got CKD, chronic kidney disease. I don't know, anything complicated. You've got a mechanical aortic valve, like the guy that I saw not that long ago. Those are complex patients, and you want somebody who has seen 100 or 1,000 of those patients in their career in other settings. They know how to manage that disease process. They know the red flags, and they know how testosterone therapy can potentially influence the course of that disease. So, I hate to say it, but unless it's a very experienced nurse practitioner or PA, most of them they just don't have the clinical hours taking care of people like that, either in the clinic, in an emergent setting, or on the inpatient side, whether it's on like a medical surgical ward, if they get admitted to like the medicine service, or they're really sick and they're in the ICU. There's an advantage to having a board certified MD or DO taking care of you if you've got some of those issues. It's not universal, guys. There are some fabulous NPs and PAs out there that are actually, again, as good or better than many of the physicians I've seen who take care of TRT patients. So that's on a case-by-case basis. But if you just look at like total hours, this is this chart here that maybe might surprise you guys, because I hear it all the time on the forums, guys bashing their family doctor and bashing their internal medicine, their primary care physician. This guy's an idiot. This guy's an idiot. I promise you he's not an idiot, or she's not an idiot. So for me, as an example, I did my first residency in family medicine. In order to get there, I had to do 4.5 years of undergrad, because I took some extra classes I liked. I took some extra anthropology classes because I thought they were interesting. 4 years of real medical school, real MD medical school, not chiropractic college, not naturopathic medical school, like real deal MD medical school in the late 90s. And then a 3-year family medicine residency, which I did before the 80-hour work week restrictions that they put in back in 2003. So for me, and for the average family medicine doctor, internal medicine doctor that does a 3-year residency, that comes out to about 20,000 hours, okay? 20,000 hours of training. So not including undergraduate. So between didactic and clinical, and the clinical is really what matters. And that's the bulk. Like that's what makes you a physician, is the clinical hours in residency. So you get about 5,000 didactic hours in med school. And then in 3 years, they cram in 15,000 additional hours of bedside training, taking care of really sick patients in many cases. So you can compare that to, you can see on the chart here. So PA school, it's kind of split half and half between didactic and clinical. So we're looking at like just under 5,000. FNP, so family nurse practitioner, they come with a bit more. It's a little bit, looks like a little bit over 5,000. And then the naturopaths are about the same as the PAs, mostly didactic, very little clinical. Get some hate for this, but naturopaths, they're not real doctors. They don't know what the hell they're doing. In most cases, they are better than MDs and DOs when it comes to nutrition. That's it. So feel free to leave me all kinds of hateful comments. I don't think naturopaths should be allowed to prescribe medications, in my opinion. I just don't think they're qualified. I don't think they have the clinical experience. So I would think twice if I was being managed by a naturopath. Anyway, it's not to go off on a rant, but I'm a little salty about the naturopaths. That's just my opinion, okay? I mean, if you like your provider, you feel like they do a good job, I don't care what their background is, please feel free to stick with them. But it's just my opinion. If you're old and sick and you want to be on TRT, that's not a contraindication in most cases, but you want to have a physician who is very well versed in whatever your chronic medical issues are. So that's just how I feel about it. When it gets to counseling, so this is the next thing. I think your provider should counsel you on all of the available delivery methods, not just the ones that they offer at the clinic. So you see this a lot with, if their first recommendation is pellets, there's usually a reason for that. It's because they like to put in pellets. They sell pellets. Pellets are big money makers. They're terrible, in my opinion. They should be like a last resort. It's one of the worst ways to do testosterone replacement therapy, or HRT in general. When I counsel a guy, on testosterone replacement therapy, brand new guy, I go over all of the potential ways to deliver testosterone, including pellets and, injections and IM versus sub-Q, and we have topical. I even talk about troches, which are another complete waste of time. So I even talk about enclomiphene and Clomid because I want the guys to have all of the information. I want to hear it from somebody who's not biased, and then, they can decide. So I actually have had one or two over the years that when I talked about pellets were like, yeah, man, sign me up for pellets. And I'm like, I'm sorry, man, I don't do pellets, but let me refer you to somebody. I know a few guys who do, and I would just send them off to them. I think that's a red flag. If they're not telling you all of the delivery methods, they're just focusing in on whatever it is that they sell. It's a bit of a red flag. It's a bit of a red flag there. Your job as a clinician is to educate your patient, and it includes educating them in things that don't necessarily make you money. So if you want to be, a good provider, you just need to give good information and not have a financial bias. Now, the other one, this is a big one that these big box clinics do, and what I see quite a bit. Especially when you first sign up or see a clinic, it seems like it's common sense. You need to see someone with a medical license, right? So, a physician, an NP, a PA, etc. Your care should not be dictated by a patient care coordinator, non-physician, non-medically trained person. Okay. What these people are doing is they're practicing medicine without a license. And, I understand that, some of them are very knowledgeable. They really are. I've met some that are like pretty sharp. They know more about TRT than, again, like your average Joe family doc or internal medicine doc. However, they're not physicians. They shouldn't be practicing medicine. And you should, at any point in the course of your therapy, anytime you want to, you should be able to talk to a licensed medical professional. And in my opinion, your medical follow-ups where they review your lab should not be reviewed by someone without a medical license of some kind. I think it seems like common sense. And I honestly don't understand how these clinics get away with it. It sounds like a huge amount of liability, because if something is missed, something that this non-medical person overlooks, and there's a bad outcome, I mean, it sounds like a lawsuit just waiting to happen, but it still happens. And it's actually like common practice in many of the clinics in the United States is, you ask them like, well, I saw the doctor like for the first visit, but the last 3 years, I've never even spoken to a doctor. I mean, he just rubber stamps my prescriptions, but when I call or when I do my follow-ups, it's a patient care coordinator. And, you're taking a risk with that. The other one that's a huge red flag is, I've seen more and more of these big box clinics do this. They have like, it's a membership. It's a membership program. So instead of like a concierge medical practice where maybe you pay by the month, they treat it like a gym membership. Like you sign up for 6 months and you're stuck. Like you are stuck with that clinic. If you're not happy with the care, or they're giving you substandard care, which I just became aware of one here recently through a consult that was doing some really ridiculous stuff, and he wants to leave. He's like, I can't leave. I've already paid the 6-month fee and they won't refund me. Guys, this is healthcare. This is not a gym membership, right? It's not a social club that you join. You should be able to leave whenever you want to. Okay. I have no problem with monthly fees. I mean, in my practice, I do a monthly fee, but you know what? You can quit the practice absolutely anytime you want, and I'll refund you that pro rata that last month. Like it's completely fine. That's the ethical thing to do. It's not a gym membership, but many of these places, they're being run like a gym membership. Once you sign on the dotted line, you're in for 6 months, a year, whatever it is that they have on this contract. So, and many of these same clinics and a lot of clinics, this is a huge red flag. If they are telling you that you need to manipulate an estradiol, like this, I've talked about this ad nauseum, so I don't want to go into it too much, but especially if they want to put you on an anastrozole right out of the gate on day one, huge red flag. Just in my opinion, I would just be like, I'm out of here, walk away. They don't know what the hell they're doing. If they're using compounded testosterone that has anastrozole baked into it, which is available at some of these compounding pharmacies, it's atrocious. It's terrible. They think that they're making it convenient, but these people, they just don't read the literature. They don't know what they're doing. This whole notion that they talk about where you have to keep estradiol within a sweet spot in the serum is completely false. And these are the same clinics and these same influencers that they love to use the term like dialed in, which like makes my hair stand up on end every time I hear somebody say, I just need to get my estrogen or I need to get whatever dialed in. Like, listen, man, you're not a shortwave radio, right? There's no, you don't dial in estradiol, especially serum estradiol, by manipulating it with anastrozole or, other ways, because again, what I have extensive videos on this. What you see in the serum does not reflect what's going on in the tissues. And there are multiple studies, which you can watch in my other videos where I talk about this in detail. Tiny manipulations in the serum can have dramatic effects at the tissue level. So, these people are deluding themselves into thinking that you have to dial in a level of like, 20 to 40 seems to be what they like. Like that's the sweet spot in terms of serum estradiol. And, God forbid, you don't want to get, your serum estradiol greater than that. And, you don't want to go lower than that too. Cause, we all know that, crashing estradiol guys, no, it's honestly, I wish it worked. I wish it was that easy. It's not. So, in my opinion, they shouldn't even be checking estradiol levels. The same goes with DHT. Clinics still do it. I don't care. Feel free to disagree with me, but that's the sign of a provider that is practicing medicine from like 10, 15 years ago. Because that's what we used to think. That's when I took some of my very first training courses in HRT. It was standard protocol to use AIs to manipulate estradiol and get it into that quote sweet spot to dial you in like a shortwave radio. That's not a thing. It's not a thing. It's a huge red flag. All right, enough on that. I could go on forever on that. Fertility. This is a big one. You need to be asked if fertility is on the table for you. A lot of clinics, I'm still surprised to this day, don't ask. And sometimes they just assume because a guy is over the age of 50 that he obviously doesn't want children. And that's not the case. I'm 52. I have a 1-year-old. Okay. And I have a 3-year-old and we're probably going to have some more. So, you need to ask. And if you don't want kids, great. But at least they asked, right? I took care of a kid. Gosh, this is probably like 10 years ago now. Maybe a little bit less. Guy in his late 20s was being managed for a year by a naturopath. Because in the state of Oregon, naturopaths are allowed they have full prescribing privileges. So literally they can prescribe chemotherapy. They can prescribe anything that I can as an MD, they can prescribe. It was like, yeah, we're just, my wife and I have been trying for a year and we're having trouble having kids. And I'm like, dude, you're on testosterone, right? He's like, oh, yeah. Like, did they tell you that this can impact your sperm counts? And he looked at me like, no, and he didn't know that. And he didn't know that. This physician, I use the term lightly, like never counseled him on the fact that, testosterone replacement therapy can lower your sperm counts. So it took me a while to like undo that. And thankfully, eventually he was successful. That needs to be addressed out of the gate. And if the answer is no, great. It actually, makes it easier for everybody. If you're done having kids or, if you've had a vasectomy or whatever, cool. We don't have to worry about that, but they really should ask. The next big red flag, and there's some controversy and nuance here, it's the hematocrit and blood donation thing. Endocrine Society, American Urological Association, several other bodies around the world, they tend to say 54% is the sort of the cutoff, where potentially above 54%, blood viscosity increases their theoretical risk for thromboembolism. So, stroke, DVT, deep venous thrombosis, pulmonary embolism, etc. You have to understand that number is a made up number, and it's well documented that it's a made up number. The panel that came up from the Endocrine Society that came up with their guidelines regarding testosterone put their heads together, and this is the number that they came up with that they thought was reasonable. So it's not like your risk, once you cross 54, that your risk just shoots through the roof. The fact is the overwhelming amount of evidence shows that there is not an increased risk with simple hematocrit elevations in an otherwise healthy person, as long as it's from what's called a secondary source. So like testosterone, altitude, etc. Highly, highly debatable. It's contested. So the real red flag with this one is not so much if you hit 54% and they want you to donate, I don't I don't begrudge them that because listen, that's in the guidelines. And so there's medical legal risk, right, for that clinic and for that provider. If, God forbid you do get a blood clot and on the day you go to the emergency department, maybe you're a little dehydrated and you happen to have a hematocrit of 55%. Well, everybody is going to blame the testosterone. They're not going to blame the obesity, the smoking, the factor V Leiden genetic mutation that you might have that really caused the clot, or the underlying cancer, all these other like very common risk factors, or the fact that like you just had major orthopedic surgery, a hip replacement, a knee replacement, like all those things like skyrocket your risk of having a clot. No, it's absolutely going to be the testosterone that did it. And there's going to be no shortage of plaintiffs' attorneys, law firms, and paid expert witnesses that will say that it was the testosterone. So they do it for medical legal reasons. So you know what? That's fine. But what they should be doing is altering your protocol so that you don't hit that 54%. Okay. They shouldn't routinely, this should not be managed by a routine phlebotomy because eventually you're going to become iron deficient. So the big red flag is if they make you donate at anything under 54%. So many of the clinics that I have seen in the past and patients have come to me from clinics, they use 50%, which is, it's totally made up. There's no increased risk that anybody can prove that you cross into 50%. And, many of them they'll literally like withhold, they're not going to withhold therapy. They won't refill your prescription until you phlebotomize yourself down to a hematocrit under 50%. And again, what inevitably happens to these guys? They get iron deficient, their ferritin crashes, they feel terrible. And then it can be a kind of an ordeal to dig them out from that. So the way to manage elevated hematocrit, if it needs to be managed at all, is to manipulate and to adjust your protocol. And I won't go into that here because it's not relevant to this particular talk. I have other videos on that, and there's some other really good ones that are on YouTube as well if you want to figure that out. But that's the phlebotomy is not the way to do it. Okay. At least like chronically. You don't want to do it chronically. If you want to donate every now and then, like I've said before, I donate twice a year on average. I do it. I've got O positive blood. I use a lot of blood products in my hospital practice. So it's my way of contributing to the supply. So I'm not saying don't donate blood for those reasons, but if you're one of these guys where your clinic is making you go every 2 months, that's just asinine. It's a huge red flag. It's another example, like you're probably being taken care of and treated by somebody who doesn't really know what they're doing when it comes to this whole thing. So next one, moving on. This is another big one, add-ons. If they are constantly pushing add-ons to you, and what do I mean by add-ons? Well, they'll give you the TRT at a base price, but we need to sell you some anastrozole. Peptides, you definitely need to get on these peptides. So if you have a problem with your protocol, for example, or let's say your symptoms are not completely resolved, libido is a good example. So your libido is better, but you're still not what you think it should be. And their answer is to sell you like PT141 as a peptide and not adjust your testosterone dose or manipulate your protocol in some way as a first-line agent. It's a first-line method of correcting that. Again, that's a huge red flag. So these adjuncts are big money makers for clinics. They make a lot of money by selling you extra shit that you don't need. And that includes nutritional supplements, guys. There are cases where getting like compounded pharma grade nutritional supplements, probably a good idea, like good high quality melatonin and, glutathione if you're into that sort of stuff. But most of the time you don't need to spend that extra money, and they should not be in the business of selling supplements. That's just my opinion. I know that many of the clinics do, and that's fine. I mean, we all got to pay our bills, but they shouldn't be pushing them on you. They should educate you about them, say that we offer them, and they should not be pushing these adjuncts on you. And the big one is like oxandrolone. So, formerly known as Anavar when it was more widely used here in the United States. In my opinion, listen, if you're in this for health and longevity, there's zero place for oxandrolone. Okay. If you kind of want to do a steroid cycle and you want to get a little more jacked, go ahead and use some oxandrolone. Okay. But don't let them tell you that using oxandrolone is going to improve your overall health in any way, especially chronically. It's not a good idea, guys. It's a money maker, and it's a way to sort of legally get anabolic steroids, guys. And, there's a lot of guys that want to do that. No judgment. I wouldn't do it. I don't prescribe it. I don't think it's a good idea. It can potentially shorten your life if you take it chronically. It can skew your lipids, and I don't think it's worth it. So to me, that's a red flag. All right. It goes without saying, like the healthy lifestyle stuff, if they're not like every time you follow up, if they're not getting your height and your weight, maybe not your height, your weight, your blood pressure, they're not asking you about your sleep, your nutrition, your stress levels, your relationships, like all these things are way more important in many cases than just like your T level. Like all of this works together. And if all they care about is, yeah, your hematocrit's good and your T levels are good, let's swipe your credit card, get you a refill, and we'll see you in 6 months. Well, you get what you pay for, unless you're very well educated in those areas, like some guys are, and you feel like you can, you don't need any additional help in the diet, lifestyle, training realm. Okay, fine. But most guys do. Like most guys need a lot of help. And if your clinic is not at least doing that to some degree, I think that's a red flag too. Okay, these are these two final ones, and these ones really get under my skin, because if your provider, your clinic is doing these, giving you one or more of these three things and telling you that this is a substitute for HCG, this is a way to maintain fertility, etc., they have no idea what they're doing. They skipped the endocrinology lectures in their whatever medical school or training program they went to. They haven't cracked a book, and they haven't read anything about the HPTA axis since 1986. And I say 1986 because the initial studies that showed some of the things that I'm going to show you, they date back to 1986. So we've known this for 40 years. So there are still providers out there. I just watched some video of a female nurse practitioner talking about, how great it is to add kisspeptin. And that's one of the ones I'm going to talk about. Kisspeptin into your TRT protocol. I'm like, okay, tell me you've never read an endocrinology book without telling me you've never read an endocrinology book or a physiology book. Again, these are financial tactics. They're money makers for the clinic, but it's a huge red flag in my opinion. So let's start with the first one, which is adding N-clomiphene to your TRT. So this started becoming popular when we could no longer get compounded HCG, the price went through the roof, because now, at least in North America, it's brand name Pregnal only. So the price just, at least tripled in some cases. So clinics started looking like, okay, well, we can add N-clomiphene in here. And the idea with N-clomiphene, if you just take N-clomiphene in and of itself, it does raise LH and FSH levels, which in turn raises testosterone levels. It can improve fertility. But when you add it to a TRT protocol where you're getting a reasonably solid dose of testosterone, 100 to 150, even 200 milligrams a week, it doesn't work. It does not work. And let me show you why. So here's a very quick little overly simplified diagram of the HPTA axis that somehow some of these doctors, PAs, nurse practitioners have somehow overlooked. All right. This is how it works. So I want you to focus on the left side here. Latex cells, they make testosterone. Okay. Testosterone goes up and it inhibits LH and FSH production first up at the hypothalamus. Okay. There's a group of cells. There's a system there called the KNDY network, which K stands for kisspeptin. Okay. When those are stimulated, they secrete GnRH. GnRH is also known, the medicine is gonadorelin. So just GnRH equals gonadorelin, essentially. That stimulates the pituitary to make LH and FSH. All right. So there are three brakes that are put on this system: estradiol, testosterone, and DHT. Okay. All three of these will inhibit, they go up, not just testosterone. It's the two main metabolites of testosterone, right? So estradiol, DHT, and testosterone, all three independently can suppress the HPTA axis, okay? So this idea that we can block estradiol at the CNS while we have high, normal, or elevated levels of DHT and estradiol is completely false. It's like having 3 feet on the brake of your car and we're taking off 1 foot. There's still 2 feet on the brake. Okay. This is well documented. Again, one of the first studies that looked at this, they took guys, they blocked their estrogen all the way down to 0. Okay. And they gave them DHT and guess what? LH and FSH eventually went to zero. Same thing, you block estradiol and DHT and you just like give them testosterone only, LH and FSH go to zero. Okay. So if you don't believe me, if you're going to one of these clown clinics that is promoting you or telling you to take enclomiphene in addition to your, intramuscular subcutaneous testosterone dose, ask them to run an LH and FSH if you don't believe me. Okay. With your next set of labs. And, tell me that your LH and FSH isn't suppressed. Go get a semen analysis, and don't tell me that your testosterone, that your semen numbers are in the complete toilet. Okay, it's totally unethical, and it's just like, this is obvious. We have known this for 40 years. We've known that this didn't work. Okay, it took me literally less than 5 minutes to go on PubMed when I started seeing this and pulling up the studies and reading them. And it was like, I can't believe that they're doing this. This makes absolutely no sense. But it does make sense when you look at it from a financial standpoint. So guys, if they're giving you enclomiphene with your TRT, if you're on 150 milligrams of testosterone and they're wanting you to take enclomiphene with it, huge red flag. Because if they don't know this, which again, we've known this for 40 years, again, what else don't they know? This is probably the tip of the iceberg of the stuff that they don't know when it comes to hormones, when it comes to just practicing medicine in general. So huge red flag. All right, let's talk about the gonadorelin and the kisspeptin, because I'll kind of lump those together. So again, gonadorelin started getting popular when we had a bottleneck with the HCG. So they're like, okay, well, we can't get you HCG, or it's very, very expensive. So an HCG is an LH analog. Instead of, let's go up one step on the HPTA axis, we'll give you GnRH, or gonadorelin. That should work, right? It stimulates LH and FSH. LH and FSH should stimulate both testosterone production and sperm production. Great. Sounds great. Again, if they had just taken literally 10 minutes on PubMed, it took me to find this diagram here and find all the papers that show why this didn't work. And all it takes is looking in an endocrinology textbook and looking at the way that gonadorelin is used, which is in a pulsatile fashion, at least 5 to 6 times per day. And it's usually given in something that looks like an insulin pump. So if any of you guys are like type 1 diabetics, you have an insulin pump, they make something similar like that for a gonadorelin. It's very expensive. It's very uncommon. I've never actually seen it in clinical practice, but apparently it's out there. You'd have to probably go to a specialty endocrine clinic that treats these sort of disorders. So the reason that it's given in pulses is because the effective half-life is next to nothing. Okay. So this is what happens when you do a sub-Q injection of gonadorelin, which the way that these clinics are doing this, they're usually having guys dose it, many of them twice a week, sometimes 3 times a week, kind of in the same way that you dose HCG. And HCG works because it's got a very long half-life, and its effect on LH, the LH receptor, lasts for many days, right? So that's why it works. This is gonadorelin, and it's actually compared to these other 3 GnRH analogs. There's actually other ones out there that are used in research settings and in like very specialized endocrine clinics. So gonadorelin is this is the black circle here. So when you get a dose of gonadorelin, yeah, you get a nice spike in LH, FSH as well. Cool. Well, the half-life of LH is about 20 minutes. Okay. So you get a spike, you get up here, it looks like levels were just over 10 nanograms per ml. So that's pretty cool. And then look, and that's within the first hour. They start dropping off immediately. And by hour number 4, your LH levels are basically back to zero. So you get a 4-hour spike in LH. You get a little bit of longer spike in FSH, but not too much more. And then it basically goes down to zero. It's totally, totally inadequate to maintain fertility, totally inadequate to maintain intratesticular testosterone production, which is vital for normal sperm production. It doesn't work, guys. It does not work. So you get a 4-hour blip of LH every time you inject gonadorelin. That's why it makes sense, right? You have to do it 5 times a day through one of these pumps. And you know what? Those pumps actually do work. There's plenty of papers that will show you nice steady LH levels, nice steady LH, FSH levels, and return of sperm counts to like relatively normal levels. But it's just like so expensive, so tedious. Nobody does this. again, outside of like very special endocrinology clinics. And guess what, guys? It's the same thing with kisspeptin, okay? So again, you get a single dose of kisspeptin, it does exactly the same thing. You get a nice big, like robust spike in LH, okay? And then it works its way down. Then you get a little spike in GnRH. So you give the kisspeptin, like within 15 or 30 minutes, you get the GnRH spike, which lasts, like it peaks at like 45 to 60 minutes is what they say. But again, within 2 to 3 hours, that GnRH level is right back down to normal. So the stimulus is gone. You get a little bit of LH, you get a little bit of FSH for a few hours, and then it goes away. So it's a complete waste of time, guys. But it does make a lot of money for these clinics, right? So you got to wonder, again, why are they doing this? Why are they doing this? Either they don't know, in which case you got to question their medical knowledge, right? You got to question their competency, or they do know and they're trying to make a buck. Neither one of those are good. Neither one of these are a good look, okay, for these clinics. So if your clinic is using N-clomiphene, gonadorelin, kisspeptin, or any combination of those, huge red flag, doesn't make sense physiologically. The information that shows these doesn't work is readily available. It's been around, like I said, in some cases up to 40 years. There's no excuse for them not to know this. There's no excuse for them to be prescribing this. I don't care what they say. Oh, I've seen it work. No, you haven't. You haven't seen it work. It's not in any of the published studies. And you know what? If you have seen it work, then my answer is always the same when I get pushback. Well, I've seen it work. Listen, if you're a physician, you need to publish that. You need to at least publish a case report, because if you found a way to make this work, okay, you're going to revolutionize reproductive endocrinology, okay? But to date, I have yet to hear, I can hear the crickets. I've yet to see a case report or any sort of study from these guys published in a legitimate, like peer-reviewed medical journal where we can all the doctors out there in the world can look at this data and maybe we can start using this stuff because you found a way for it to work. It's never going to happen because it doesn't work. It goes against basic physiology, guys. Okay. All right. That's the end of my rant. Guys, I know there are more red flags out there. If I've left any out, which I'm sure I have, please put them in the comments. It'll be a good discussion. And I'm sorry I got a little fired up about this, but I really feel strongly about this. This is a field that I care a lot about. I can't stand seeing guys get ripped off and taken advantage of by these snake oil salesmen. It drives me crazy. So I have to limit my time on social media because it makes my blood pressure go up every time I hear some of these clown influencers and clown clinics out there saying stuff that, is just completely wrong medically. And it's borderline, and maybe not even borderline unethical for them to be doing this stuff. And I hate to see you guys getting taken advantage of. So anyway, I'll leave it at that. I hope you guys are doing well. I'll catch you next time. Bye-bye.
All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.